depending what the experience has been of that person and their family and their support team and their caregivers, they may be worried about disclosing the swallowing. If they've seen someone go the route of, oh, well, Tommy went to the hospital for a broken hip and came back with a feeding tube.
What do you think isn't well known about dysphagia or swallowing difficulties in adults with intellectual disabilities?
They don't read the textbook. They do not read the textbook. Okay, this man that's being fed in this way that shocks me to my eyes. He's never had a respiratory infection. He's never had any issues that one would equate with, oh, that's got to be a high aspiration risk for something. Okay, well, maybe check yourself. Like, if the evidence isn't there to support it, like, then you have to realize that that's maybe coming from a place of bias. It's like, it made you feel icky and you didn't like it. That doesn't mean it's wrong or not functional for that person.
So where does this research come in? Research Bites.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speeches, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. Today, we're joined by Jen Beener. She's a speech-language pathologist with over 10 years of clinical practice experience. She received her Master of Science in Speech-Language Pathology from New York Medical College in Valhalla and is currently pursuing a PhD in Health Sciences at Seton Hall University. She has extensive experience in dysphagia diagnostics and management across residential and medical settings. Jen has presented on dysphagia in adults with developmental disabilities for local, national, and international audiences, and she currently teaches undergraduate and graduate SLP students alongside her clinical work providing mobile fees to over 30 medical facilities. Welcome, Jen.
Thank you so much. Thank you for the lovely introduction.
So the study we're basing our discussion on today looked at the prevalence of swallowing difficulties in older adults with intellectual disability, and the researchers used a dysphagia disorder survey to assess over 1,000 people and then compared those findings against what was actually documented in their medical records. They found that nearly 44% had swallowing difficulties, but more than 83% of those cases weren't recorded anywhere in their medical history. The study also identified frailty, mobility impairment, and mealtime dependency as factors independently linked to swallowing difficulties. Jen, I'm curious, what terminology do you use when you're working with this population? Do you use dysphagia? Do you use swallowing and feeding difficulties? Yeah, what do you use?
Yeah, so I'm in New Jersey, New York area in the United States. So I think dysphagia when we're working with adults tends to be the more predominant term. When we say feeding, people tend to think pediatric. And in my time when I worked exclusively with adults with developmental disabilities, I found that extremely frustrating because much of what I was seeing kind of related to, okay, I have concerns about airway protection and pharyngeal swallow efficiency, which for me is like, okay, that's like capital D dysphagia. And then, well, I'm seeing issues with oral containment and overstuffing and taking an appropriate size bite that's going to be well managed. To me, that's more of a feeding issue. So I found myself kind of straddling the fence of pediatric and adult terminology based on what I had learned in my education.
Yep. And it makes it hard in research as well, doesn't it? Because I was, trying to find
Absolutely.
trying to find studies on, dysphagia in adults with developmental disabilities, but a lot of people refer to it as a feeding and swallowing disorder. And I think with the dysphagia management staging scale, I think that's the terminology that they use as well, a feeding and swallowing disorder. So it makes it hard when you're trying to find the information, but you might not be using the terms that everyone else is using.
Yeah, I do think the broader, more descriptive terms are important and I do think are better. In this setting where you're trying to kind of characterize everything related to someone's mealtime safety and independence.
Yep.
When you're just focusing on what I think most practitioners would call a dysphagia, a lot gets left out.
Hmm.
And I see that now in clinical practice, focusing on providing flexible endoscopic evaluation of swallowing, where I mean, talk about hyper focus on the swallow. I'm in there really just directly looking at pharyngeal efficiency and airway protection.
Yeah. When we're working with adults with intellectual disability and even adults with, acquired cognitive impairment, the environment, the person who's assisting the person with swallowing difficulties, that just becomes so key, doesn't it? So if we're just focused on the,
Yes.
physical dysphagia, we're going to be missing a lot of things.
So much. There's a term that, when I was trying to navigate the lack of resources when I worked with adults with developmental disabilities exclusively, I found myself really gravitating towards pediatric literature and practice because a lot of it because of the use of the term dyad, the feeding dyad. Who is that other person involved in feeding? I was receiving adults from the community who were moving into residential care, and they had lived with their parents for 40 years, dependent for feeding for 40 years with mom and dad. What does that feeding relationship look like? And I know if I did the evaluation where I fed that person and that's my first time seeing them, I am missing a lot. I'm inadvertently manipulating the environment and creating a very artificial feeding situation, where I really need to watch mom and daughter or dad and daughter the way you would emphasize with the pediatric evaluation. But I think that can get missed sometimes. I also found as a new clinician in that setting, there were so many things that just immediately jumped out like, oh, this isn't right. This isn't right. Because I, was only shown certain things and came out with a pretty rigid view of what eating and drinking is supposed to look like. And then you look at the history. You do the thing that'll never be shown on a brochure advertising what speech language pathologists do, which is sitting at a desk and reading. But I think that's where a lot of our magic happens, where we do a chart review. Okay, this man that's being fed in this way that shocks me to my eyes, he's never had a respiratory infection. He's never had any issues that one would equate with, oh, that's got to be a high aspiration risk or something. Okay, well, maybe check yourself. Like, if the evidence isn't there to support it, like then you have to realize that's maybe coming from a place of bias. It's like it made you feel icky and you didn't like it. That doesn't mean it's wrong or not functional for that person.
Right. Yeah, I think all of my clinical placements at university were done in a hospital. And then that's where I started working, seeing clients with acquired conditions, stroke, things like that. When I saw my first client with intellectual disability and cerebral palsy, I was extremely worried and shocked with what I
Yeah, like where
saw.
do you start?
Yes, it is completely different. So I'm sure there's a lot of clinicians out there if they're just starting to work with this population. There is definitely that initial shock before you understand. Okay, so this is what's normal for this person.
Yeah, it's kind of like if you've always put together 2D puzzles and then someone gives you like a 3D puzzle to like build like a tower and you're like, oh my gosh, I don't even know. Like everything seems to not fit the way that I'm used to it fitting.
Um, I want to mention something in the study. I think they found that was it over 40% of adults with intellectual disability had swallowing difficulties, but then 83% of those cases weren't documented in the medical records. I wanted to ask if that figure
So interesting.
surprised you. What do you think about that?
I'm only surprised in how eloquently they described it. I am not surprised by that finding at all. And I think it's very clever in how they were able to kind of uncover that by using data from this healthy aging study and also incorporating the medical record, and specifying like that these professionals are experienced in intellectual disability. And I think actually, if they were to add another layer, I'd be curious to see what the use of the word dysphagia is.
Mm.
Because I think like when you look at a medical model, at least in the US, like we really are looking for like dysphagia, like that term. And a lot of things like they call it like I think they use the term like under recognition of swallowing difficulty. I think also a lot of, depending what the experience has been of that person and their family and their support team, and their caregivers, they may be worried about disclosing a swallowing if they've seen someone go the route of, oh, well, Tommy went to the hospital for broken hip and came back with a feeding tube. They
Hmm.
may be scared to even say, oh, that, my loved one's been having some difficulty because they may think, oh, it's going to turn into this big, domino effect of like, oh my God, once they get a hold of him at the hospital, they're going to do this and this if we say that he can't eat. Because really, there's so much gray area, but sometimes in a medical model, things become more binary. Like they
Hmm.
can't eat, they can't eat. They pass, they fail. We hear that terminology a lot in the US. You're nodding. I'm guessing it's common
Safe,
elsewhere to
unsafe.
say,
Yep.
yeah, safe, unsafe. Exactly. So there even could be presumed difficulty when it was just a one-off. Someone was laughing while they were eating and had a one-off the same way anybody else could. But when there's such a watchful eye and so much of their life is pathologized, it's like, oh no,
Mm.
forget it. That's dangerous. We can't do that.
On the topic of choking, I find this tricky sometimes to manage sort of choking risk. I know that we have the choking risk assessment, the CRA, by Justine Jones Shepherd. I think almost everyone gets classified as high risk
Yeah.
on that because I think you just need maybe three items, 30%, then you're
Yeah,
already
yeah,
high
it's not
risk.
hard.
Yeah, it's I find it really tricky sometimes to, reliably say that, this person is at high risk of choking. And if a person hasn't had a history of choking, does that mean they're okay? But well, there's always going to be a first time. Just
Just takes
interested
the
to get,
one, too.
yeah.
Yeah,
I'm just interested on your
yeah,
thoughts in how you sort of go about evaluating, choking risk.
yeah. So the choking risk assessment is a good resource. I think when you have access to instrumental imaging like FEES or MBS, using it as a biofeedback tool. I remember one case, now this was not a man with intellectual disability, but sometimes the image is very obvious that I think a lot of people would understand. You don't have to give a patient a full anatomy and physiology lesson to show them like a piece of food in their throat. Like if they have a camera in their nose or the camera next to them and say, this is what looks like inside, and you show them. I mean, fees is like a true image. So it's like, it's very obvious. I had one gentleman that I was scoping and he was putting in so much effort to chew, really, really, really so much effort. I could see he was trying so hard. And he was really motivated to have coleslaw. He really wanted coleslaw. That's raw cabbage, gently softened, but it's raw cabbage. Very difficult. And that cabbage was staring back at us in the pharynx, like creating a bridge across the area of a lot of folds. Like very, we're all like little tense in the room watching. So I showed him like that's after as like you put in so much effort chewing and you really, gave that cabbage a run for its money and it is staring right back at you. And he said, listen, somebody has to chew it. Somebody has to chew that. It could be you, but you were trying your darndest. And that was with no distractions, no
Mm.
grandkids running around. Or the kitchen can do it. Or you can do it on the plate. Those are like three broad categories. Who can chew this cap? You tried your hardest. That was really difficult. He's like, yeah, I was tired. He's like, okay. He just swallowed whole, by the way. I wouldn't have had this whole conversation if it's just sitting there. Yeah, a lot of people, they look at like, oh, don't modify diets. It's like, wow, we can't be like, you can't throw out the baby with the bathwater. A lot of families are already doing it and they've figured out things that work and they don't necessarily have the clinical tools or vocabulary for it. And back to your question, Chantelle, about the assessment, when I've had the opportunity to have family bring in food or feed how they would feed it, because it isn't just the feeding itself, it's like what's on the plate.
Mm.
Because you'll see a hamburger turn it, I mean, literally turn into a minced moist. I mean, you have people, they go at it with like two forks and like squirts
Mm.
of ketchup, and it's like, oh my God, it's like I was not gonna even think that that's how that burger was gonna end up in your son's mouth. Giving people a chance and open-ended, judgment-free opportunity to kind of show you. I know we totally strayed from your question, but there we
That's
ended up with a minced burger.
totally fine.
Um, the feeding, so food consistency, choking risk. Yeah, I mean, if education could be a component, like for me, that's a huge part of shared decision making, but choking, a lot of it is environment. There can be a tendency to kind of like go into like a policing role, or just like, well, I'm the clinician, so what I see is right. And it's like more people can be right and have different observations at different times of day and things like that.
Yeah.
Especially when you have complex medical conditions, a lot of different medications that people take, the level of alertness and attention can really fluctuate, susceptibility to distraction, like all sorts of things. So
Hmm.
chances are whatever you see at one meal is it could be very different than another meal.
I've read in a few articles that the more severe the intellectual disability, the more likely it is that the person will have dysphagia. Why do you think that is?
That's such an interesting question. So this article used IQ
Mm,
as a severity measure, which is already like IQ is very interesting as a measure because it focuses very selectively and it omits a lot of like functional things related to ADLs and behavior and perception. So yeah, I mean, sure, is there critical thinking and reasoning and spatial awareness when you eat? Yes, those are parts of meal times. If you're working with adults with intellectual disabilities and you have people in their 60s or 70s, which would largely be in this group, focusing on over 50 years old, depending what their childhood was like, they may not have ever been really diagnosed with anything formally.
yep. Yeah.
I've seen a lot of just like the term autism just used on like, well, it's something, so let's call it autism. I was like, well, it doesn't match any of the features of autism, but okay, sure.
And those things
That's
stick, don't they? Once it's written down
those
somewhere,
things
that
stick once
follows
it's
the
written down.
person.
Absolutely.
Hmm.
Absolutely.
Um,
There's also, oh no, go ahead.
there you go.
I was gonna say, like, also depending on what the childhood was like in the early residential environment, if someone was in an institution, like there's some institutional practices that were put in place that could give you the impression that someone has a swallowing difficulty when they don't. A lot of places did and maybe continue to just modify all the food or put everybody on thickened liquids.
Mm,
There's even been the practice of removing people's teeth
oh my
just
gosh.
proactively. Yeah, so there's a lot of work to be done.
Mm,
But it was thought, well, they're going to get cavities or whatever justification was given. Of course, it's not beautiful, but they're not chewing, they're going to get cavities. It's more to take care of, something like that, or they're biting. Was it done behaviorally? But that was a commonplace practice to just remove people's teeth in institutional settings.
oh gosh, that's shocking.
Yeah, spooky stuff.
Mm,
But I could see that person, they're a dentist. That doesn't mean that they can't chew. That doesn't mean
mhm.
that they have difficulty, but they've had reduced exposure.
I want to ask you something. So I've heard you say before that mealtime dependency isn't a risk factor for aspiration pneumonia in the developmental disability population because they've always eaten that way. In this particular study, they flagged mealtime dependency as a risk for swallowing difficulty. And in Justine Jones-Shepherd's 10-item pneumonia risk assessment, feeding dependency is also listed as one of the risk factors. So I wanted to get your opinion and your thoughts on
Yeah.
that.
This has been like a soapbox of mine because what ends up happening with mealtime dependence, and I'm glad you brought this up, is because we have the traditional predictors of aspiration pneumonia based off of Langmore's research, where people are looking at a post-stroke, typically developed adult population. So general, typically developed adults, acquired brain injury, stroke, dependence for feeding. That is an acquired dependence. It's also reflecting it will tie with the stroke severity itself, their functional outcome and recovery. And I've seen that applied to adults with developmental disabilities without a conversation about, well, how long have they been dependent for feeding? What does their dependence look like? And largely looking at adults, in my experience, mostly working with adults, a lot of them who have used a wheelchair since childhood, have spastic quadriplegia and cerebral palsy, limited mobility of upper limbs, but they're dependent for feeding.
Mhm.
But their dependence is going to look a lot different than mine should I wake up tomorrow and not be able to feed myself when I've been able to feed myself. So the question is, I think one of the questions we need to ask is like, have they always been dependent? And what has that dependence looked like? And what's nice in this article is they kind of break it down that we have this independent, partial dependent, dependent, and again, unknown. No, someone get
Keeps
in there and
cropping up.
maybe ask some questions. And there was a great article, Ball et al. In 2012 that kind of looked at like the extent of these specific supports. Like what does it look like? Is it assistance getting food to the mouth? Is it the actual modification of the food itself? Is it modification of the liquids? Is it using adaptive equipment, which that alone is a huge category of types of assistance? Is it just help getting the body into position for mealtime, which could be someone who's ambulatory or not, even helping them get into a safe and comfortable position or a position that helps them be independent. Is it behavioral? Is it prompting, pacing, cueing, things like that to maybe mitigate like overstuffing, something like that? Do they need their mealtime environment modified and they're dependent for that? The dependence is like, what are they dependent for? Why are they dependent on that thing? And how long have they been dependent? Have they been consistently dependent for feeding since they were a child? Did they not have those independent feeding milestones? And I think this would be so hard to prove, but I've always been interested, particularly for those who are physically dependent because of a physical limitation, if they have compensatory strategies that they do, if someone were to try and feed me, that my body's not prepared to do. And I remember thinking about this a lot. I had a woman in particular that, if I was, feeding her one of her meals in her 50s, utilized a wheelchair all day, custom supports, lateral supports, because she had, poor trunk support, lots of spasticity, lots of uncontrolled movement. So had, feeding assistance for that, could not control her arms or hold the utensil. And I would use a flexible nosy cup to give her liquid, thin liquid. So it's like, oh, this stuff's like moving fast. You're like, oh my gosh, thin liquid. And I'm pouring it into her mouth. This is crazy. And I'd watch her, and she drank like almost everything was with the mouth like wide open. So I could get like a really good look. And I'm like, she is cupping her tongue and like holding this liquid bolus and swallowing. And she would not take, if she was not ready for the next sip, she would not take it. And I'm like, I can't do that. I wouldn't know how I'd aspirate that, communicate that with somebody, not be able to tell them what to do, speaking and explaining it to them. But I'm like, she has figured that out.
Yeah.
I also had another patient I was convinced was doing a supraglottic swallow with like no one instructing her.
Oh,
I just
really? Tell
remember
us about
sitting
that.
and like staring at her. I was watching her breathing pattern while she was drinking, and she had some interesting changes in her food and drink preferences. Yeah, I remember just that I had the luxury of like time. I wasn't the setting I was in wasn't like these like 15-minute evals and like 92% productivity and stuff. But I was like, she's really engaging in a different breathing pattern. And I'm wondering if she's actually closing that airway, probably similar to this other woman, because she was dependent and in a recline, that she's like adducting, holding, swallowing, and like actually making this alteration. Could I prove it? Like, no, not at the time, maybe another day. But just thinking like, I think I was like, I really think consciously, unconsciously, I can't say, but she's figured this out.
It's amazing some of the strategies and things that people figure out on their own without
Yes.
any guidance from
Yes.
us.
Absolutely.
I
Yeah.
want to ask
Try
you,
not to muck it up.
yes, I want to ask you about instrumentals in this population. Do you think they're useful, not useful for some? Tell me your thoughts about that.
So many thoughts. So many thoughts. Well, just generally speaking about instrumental, I just want to say like everybody's piece of the puzzle is really important. The instrumental cannot reveal a lot of things that the clinical swallow evaluation can, just as the clinical swallow evaluation can't reveal some things that the instrumental can. But I think the latter part is what we really focus on. We're like, well, you can't do this, you can't do that. I was like, well, I'm sorry. These risk assessments, all these things that don't look sexy in a brochure, someone sitting at a desk and reading with a little clipboard and making marks, like a lot of really, really, really important work. Dysphagia detective work is being done on that clipboard and in that chart review and writing things down and talking to family on the phone. But that the speech therapist on a phone will never be on the front of a brochure. It's going to be always somebody palpating or scoping or, at the MBI. And those are important tools, but like sometimes the not tangible things are really, really important. So I just want to say, like, generally speaking, whether it's population with intellectual disability or without, like simmer down if you feel strongly that one needs to be more important than the other, if they are different sources of different information. Okay, that being said, the presence of a tool does not make a test objective. So I don't like referring to like instrumental tests as objective testing. Okay. If I go in and I feel icky that this patient is drinking from a sippy cup and drinking thickened liquids and things that like I don't like, and alter my protocol based on like my perception of what this person should or shouldn't be drinking or doing or eating. How is that objective? That's not objective. So we have scales, we have protocols that if you aren't using them, and I'm first to admit, like there's things that I don't use or that I stray from. I might intend to use something, but realize like, well, I didn't administer sufficient trials of that particular consistency, or I administered them out of order. But sometimes that's what's called for, to be adjusting and flexible. So yeah, I think I've had a lot of not great experiences with sending my patients with intellectual disabilities out for instrumentals and just feeling like, wow, they focused on sometimes the literal opposite of what was being asked, like in the referral, or just not a consideration of what this person's daily life looks like and the feeding, like the environment, that feeding dyad, what's sustainable for somebody. For example, like the recommendation of thin liquids by teaspoon, and you're expected to drink 16 ounces or more to stay hydrated per meal. You will be drinking for an hour, including adaptive equipment that is either what they're already using or you're interested in trialing. I mentioned social stories earlier. Social stories, I think, can be really helpful in preparing someone to participate in a swallow study. A lot of like
Yeah.
collaboration and prep goes into it.
There's definitely more you need to do, I think, with this population to set them up
Yeah,
for success a bit more.
absolutely. Set them up for success. And I think that's also where like, and anytime I say like drawing on pediatric information, it's never to say treat someone like a giant child. It's never, never that. I think with pediatrics, we just pay so much more close attention to the role of behavior and environment and dyads and things like that. It's not to infantilize anybody. At the same time, if somebody loves their Winnie Pooh and bringing Winnie Pooh into the Floro suite is going to help, then Winnie Pooh is coming. Maybe we can put a little jacket on Winnie Pooh that looks like a little lead gown. Whatever works. It doesn't have to make sense to somebody else. Like if it's
Yeah.
working and,
We,
you know,
for one of my clients a few years ago, we completely dimmed the lights and we put on their favorite music during the video
absolutely.
fluoroscopy, and that helped. Yeah.
Yeah, and that's something that if you're the community-based therapist, if the hospital-based therapist might not know to do,
Yes, exactly.
or have the time, unfortunately, have the time to kind of trial and error
Hmm.
to figure out. You've got, somebody waiting and this and that. And so the more you can kind of do, be like, or if you can make that phone call ahead of time, be like, hey, can we turn off the lights? I'm going to bring in a little music. Most therapists should be really delighted to receive that because you're making their job
Yes,
easier.
absolutely. Um, what do you think isn't well known about dysphagia or swallowing difficulties in adults with intellectual disabilities? If there was something that you really wanted speeches to know, what would that be? And I'll put you on the spot now.
Oh my gosh, what a great question. They don't read the textbook. They do not read the textbook. And
And
age is just a number. I'll throw in another little catchy phrase. Age is just a number.
yeah, great. Can
So
I
you're
ask you
gonna
to
see,
expand on
yeah,
that? Yeah.
elaborate on that. Yeah, like, you may see an adult with Down syndrome that's in their 40s and maybe they're showing signs of early onset dementia. I mean, early is a term we use in the general, typically developed population, but might not be early for that individual. So yeah, they don't read the textbook. That's definitely one. Age is just a number. Meet people where they're at.
And when you say they don't read the textbook, what do you mean by that?
We have like every image of a pharynx, probably based off of like a 20-year-old male white med student and everything. And like you'll just see things that you don't necessarily have an explanation for physiologically. I feel like I saw a lot of like idiosyncratic feeding behaviors, just
Mm.
certain. Maybe it's lip smacking, or maybe there's tongue pumping or something. Maybe there is a reason for it. Maybe not. You may never know. And you have to be okay with just like not getting distracted
Yeah.
and looking at like, okay, but what is the impact of that?
Do you know what I struggled with, Jen? How to describe what I was seeing. There
Mm,
wasn't a word
so
for
hard.
it. There's no
No,
terminology to
no.
explain it. I'm like, I don't even know what to write down right now in my notes.
Yeah, I think I just accepted. I'm like, I'm just going to be writing novels. I think being very descriptive and practicing like neutral language. I remember reading a study, an MBSO was done on one of my patients, and she had a chromosomal disorder. I don't even think it was given a name. Her parents told me she outlived her life expectancy, which is beautiful. it's amazing. It's a beautiful thing. It was a privilege to be involved in her care, but there was so much mystery, so many mysteries about her
Mhm.
life and her experiences and her medical condition. And she would often sit and she was always laughing and she'd kind of throw her head back. Her wheelchair is very upright, but she'd throw her head back like this, like a hyperextension, and then like flop it forward and then laugh and throw it back. And she must have done this during the MBS. And it
Mm.
wasn't there. It was a study before I started working there. Otherwise, I would have gone with her. And it said, tilt your head back in order to promote AP transit of the bolus. And I'm like, if they looked at her for 30 seconds before they put the floor on, they would have seen. And she just does it all the time. I don't think she did that on purpose. Maybe she did, maybe she didn't. Or maybe that was the outcome, but that wasn't the intent. So yeah, there's these like subtle, like we have a tendency, I think, to ascribe agency to things that we see, like, oh, this person did that in order to do this. And I think sometimes we just have to take a step back and just describe it.
I remember in one of your webinars that I listened to, you talked about the importance of language and also writing what we're seeing. But then, yes, we should be careful not to attribute some meaning there when we're not actually sure.
We're not sure,
Mm.
even like I like to say like patient did not follow one step commands versus cannot follow. I'm like, I didn't follow them around for 2 weeks to say like they may have had zero interest in everything I was presenting. Okay. And first off, I was doing a swallow study. I'm not assessing cognition. I've just got like a line just to like, did they, participate and like follow directions I was giving them? Like that's it. I'm like, I was not there assessing cognition. I can't say what they can and can't do.
Hmm.
I might have walked in and be like, I'm not doing anything this lady tells me.
Yep. And that has stuck with me, by the way. Ever since I listened to that years ago, I always have that in my mind right before I go to write down something. So thanks for that.
Oh my gosh, my pleasure. Yeah, I'm a big word nerd. I think a lot of us are that get
Yeah.
into this. We
And it's
think really deeply about words and how we explain things.
And it's important because it does, I know it's a cliche, but it does shape the way we think. So we need to be careful and
Absolutely.
intentional with what we're writing down.
Oh my gosh. I mean, how many times have you seen a chart and it's like patients didn't understand or something and then there was like a language barrier. It's
Yep.
like nobody used a translation service.
Or they didn't have the
Or
hearing
someone
aid in.
yeah, they didn't have their hearing aid in, or there was a sign language interpreter, and it's like, oh my gosh. Oh my gosh.
The study as well, the use the Dysphagia Disorder Survey as an assessment tool. I wanted to ask if there are any other tools or resources that you've used when you assess this population, and also, your thoughts on the DDS.
I would recommend pursuing the training for the DDS and the choking risk assessment, the pneumonia risk assessment. Um, Off the top of my head, I can't think of anything that else that's validated for this population. Um, the functional communication profile revised, it's not a dysphagia focused one, but it's really nice for communication. And I think because you are talking about the feeding aspect of things and mealtime, getting a sense of behaviors that fall into what would be included, because DDS is not as descriptive for behavior.
Mm.
Choking risk assessment, yes. But I think you can look at if you're doing a comprehensive assessment and you're doing a full like clinical evaluation, you can look at the functional communication profile revised or something similar that has like communicative behavior. I think it'll help you get a sense like, is this someone who has such oppressive speech that actually you're going to be talking during the meal, or that you can also check a box in your dysphagia evaluation, even though you're looking at it from a communication standpoint, or like someone who is maybe you really have assessed their ability to follow directions and they exhibit difficulty following directions. Well, that could be a safety concern. How is pacing going to be helpful if this person is not understanding what those directions are? So
Yep.
verbal cueing, slow down, slow down, slow down, take small bites, wah, 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 wah. That's not a helpful approach for that person. So maybe you are relying more on, okay, maybe we are going to cut the sandwich up into quarters and model self-feeding or something like that. Like you're not going to rely on a very verbal mode of support for that person if you've assessed them and their communication abilities. So I do think pulling in from validated communication tools can be helpful. And then just good old caregiver interview. I mean, I've even included, even though I've assessed someone that's in their 40s, I asked about developmental milestones for feeding. Maybe not in as much detail as a assessment of a 4-year-old,
Mm-hmm.
but it is interesting to know, was there progression? Was there regression? Did they kind of meet a certain place and stop and plateau in their skill set? And then just a good old list of favorite foods, preferred foods, foods that they hate. A lot of times refusals, that word, that's such a coded word, like can be misinterpreted for so many things, and you don't know. It's like, no, they hate mayonnaise.
Yeah, they declined
They
it.
smell that thing you're giving them has mayonnaise on it, and they don't want mayonnaise. The same way, like I would be very upset if you tried to feed me mayonnaise, but I can communicate that to you,
Yeah.
and someone else can't. So I think just like a good, almost like a profile, just like these are likes, dislikes, these are the favorites, common distractors.
So we're just coming to the end, Jen. Was there anything else that you wanted to say that we didn't already cover in our chat?
I can't think of anything off the top of my head. I just know I was so excited when I saw you started a podcast. I was like, yeah, because I've enjoyed talking to you about this topic in the past, and I appreciate the perspective that you bring and the outreach for community-based therapists. It can be very isolating working with the population that you don't really feel like you learn about in school. Or maybe you get like a slide and you're like, but this is my whole job. How does my whole job fit on one slide? This is what I feel like I don't need things. I don't know things that I need to know. So I'm very excited to see it grow in popularity and share it with my colleagues, and just wish you all the best.
Well, Jen, I want to thank you very much for being here on this podcast. I've really enjoyed chatting to you, and I always learn something new when I do. So it's been a pleasure. Thanks, Jen.
Thank you so much.
Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye. I stuffed up my chopsticks.
One thing that you had to